I gave this presentation a few times in Korea for the implant company when they had a symposiums for the clinicians. This presentation was mainly for those who used their implant products and to anyone who were doing implant dentistry. Title of the presentation was What We Know About the Scalloped Implant. The presentation is largely in two parts. First part is about development of the implant, the rationale for developing the scalloped implant, and my personal experiences with the new generation scalloped implant in the second part. Dental implant is very popular treatment in everyday practice. Through the scientific literatures and the clinical experiences, we know that bone, implant, and the soft tissues have very complex relationships to each other. There are countless different designs of dental implants in the market today. Different implant companies have different implant designs. Implants nowadays have various shapes and designs and have different implant surface treatments and distinct implant connections. Despite of numerous different implant designs from many implant companies, the common design that is the same in every implant system is platform. They're all flat top. Flat top implant design is okay for the purpose of restoring the tooth function, particularly chewing and mastication. However, it is not the best design to reestablish the aesthetic of the tooth that's lost. One phenomena that occurs in all implant systems once the implant is exposed to oral cavity and subject to functional load is bone remodeling. There are many theories explaining the causes for the bone remodeling and how to minimize its effects. One universal fact in bone remodeling in all implant systems is that it occurs at implant platform level. Because most of implant systems, if not all, have flat top platform, bone remodeling around the implant is also flat, following the shape of the implant platform. Flat top platform implant creates flat bone architecture. This flat bone architecture is not a significant aesthetic problem in a single implant where neighboring natural teeth are present, since it's usually the natural tooth that holds and determines the soft tissue height. When flat top implants are placed consecutively, surrounding implant bone, particularly inter-implant bone, becomes flat, creating flat inter-implant bone shape. The soft tissue shape follows the flat bone architecture. This photo shows the differences in soft tissue shapes of natural teeth and consecutively placed implants. As you can see, natural teeth have scalloped shapes of soft tissue, creating interdental papilla that is a different shape than flat top implants. In dental literatures, it is shown that dental papilla can fill 5 mm from crest bones to natural teeth contact point. In comparison to interdental papilla height in natural teeth, height of inter-implant papilla is approximately 3 mm. This 3 mm height is consistent with soft tissue dimension found in dental literature, regardless of implant companies or implant designs or surfaces. Because flat top implants create flat bone creates flat soft tissue appearance. To solve the inter-implant papilla dilemma, scallop implant is suggested naturally. Parabolic implant platform design had been proposed and scallop implant became available for clinical use. The purpose of scallop implant is to promote or maintain the low facial bone level and high proximal bone height, thus creating low facial soft tissue and high proximal soft tissue appearance, mimicking the natural tooth architecture. Scalloped implant that I'm presenting is different than first generation scalloped implant from Nobel Biocare. Nobel Perfect scalloped implant design is based on soft tissue level implant, whereas new generation of scalloped implant that I'm proposing is based on bone level implant. First generation soft tissue level based scalloped implant has gone out of market and is currently no longer available. The biggest differences in clinical application of first generation and second generation scalloped implant is the prosthetic margin. Because first generation scalloped implant is soft tissue level implant, restoration margin is at the implant level, whereas the new generation scalloped implant is bone level with platform switching connection. Restoration margin is made at abutment level. The biggest problem and the reason that first generation scalloped implant has gone out of market is the amount of bone loss that occurs. The average of bone loss on this soft tissue level scalloped implant is about 4 mm. This is more than twice of flat top implants, particularly external hex implant reported in dental literatures. Typical bone level of this soft tissue level scalloped implant is seen at this level on radiograph. This is scanned photo of Nazaret's article. Red arrow shows how much of a bone loss occurs in this first generation scalloped implant. This is a dimension of the first generation scalloped implant and reported amount of bone loss. 4 mm of bone loss in this implant implies that proximal bone is resorbed to this level. Bone loss problem with this scalloped implant has been reported by Ken from Loma Linda, USA, and by Timstra from Netherlands. I was in the search for the solution for the bone loss problem in scalloped implant. I found in implant literatures that microthread and the platform switching can be the remedy for the problem. The volume of bone attaching to the proximal side of scalloped implant is small, thus it is very delicate. Microthread increases the surface area that bone can attach to. It also changes the loading force factor in bone that unfavorable forces to the bone, such as tension and shearing forces, are converted into the forces that bone can tolerate more. In an animal histomorphological comparison study, implants with a microthread and non-thread from the same company with the same implant surface has shown that implants with a microthread has higher bone-to-implant contact than non-thread design. In actual clinical follow-up study, implants with a microthread had significantly less bone loss than non-thread implants. Let's look at the benefits for platform switching. This finite element analysis study by Maeda in 2007 shows that platform switching shifts the stress concentration away from the bone-to-implant contact interface. Since the proximal bone attached to the scalloped implant is small amount and delicate, any functional load can be a potential threat to cause bone loss in scalloped implant. Platform switching can provide more biological width space for implants so that bone loss around the implant potentially be reduced. Platform switching can also contribute for thicker soft tissue biotype that less bone remodeling and potentially less bone loss can occur. There is enough evidence that platform switching is beneficial to retain the bone level and minimize the crest of bone loss than conventional non-platform switching connection implant. Let me go over my animal study that was published in year 2010. Since first generation scalloped implant had more than twice bone loss than external hex implant, I need to know how much bone loss occurs in the experimental scalloped implant that I was proposing. External hex implant were used in the study as a control to compare the experimental scalloped implant. Rationale was that if this experimental scalloped implant has similar bone loss as conventional external hex implant, then further research would be warranted for this new generation scalloped implant with microthread and platform switching. 10 beagle dogs were chosen for a split mouth study design. On one side, experimental scalloped implant were placed, and flat top conventional external hex implant were placed on the opposite side. A total of 70 implants were placed, 35 each for scalloped implant and flat top external hex implant. This is a photo of the experimental scalloped implant being placed. This is control side where external hex flat top implants were placed. Both control and experimental size of implants were placed with one-stage approach with healing abutments. After 4 months after placing the implants, the subjects were sacrificed for the histology and the bone loss measurement. This is a histology slide of the experimental scalloped implant. And this is a histology slide of control side flat top external hex implant. Overall conclusion of the study was that experimental scalloped implant had bone loss less than 1/2 of classical external hex flat top implant. The animal study validated the design of the experimental scalloped implant. Let me go over the second study on the scalloped implant that was published in year 2012. This was a finite element analysis study. First study was done in an animal with a tall healing abutment that were subject to functional load since the opposing teeth in the animal were not removed. So it is reasonable to conclude that whenever the animals were fed, the implants were inevitably loaded with functional force. In this finite element analysis study, 3 different implant designs were investigated. No microthread with platform margin model was similar to the first generation scalloped implant. Open microthread with platform switching model was similar to the scalloped implant used in the animal study published in year 2010. Closed microthread with platform switching model was a new model we were considering for actual manufacturing. All 3 had the same diameter and same length, but they had a different microthread designs and connections. All 3 implant designs were subjected to vertical load, as you can see in this slide. They were also subjected to oblique force. This was the result of bone stress upon vertical load in all 3 models. This is a close look at the vertical load stress. Interesting observation was that open microthread with platform switching model had a peak stress concentrated at the open-ended portion of the microthread. Peak stress was the highest in no microthread with platform margin model. Open microthread with platform switching had an intermediate level of bone stress, while closed microthread with a platform switching model had the lowest bone stress. No microthread with platform margin model had a stress throughout the crestal bone, particularly at the proximal area where it has the delicate and small amount of bone. This is a different view of vertical load stress in scalloped implants. No microthread with platform margin scalloped implant model had a peak stress throughout the scallop portion of the bone, which is a key point to preserve. This may explain why the first generation scalloped implant had excessive bone loss. As you will see at the next slide, peak stress significantly increases in oblique load force. This is a result of oblique load force in scalloped implant model. Peak stress was the highest in no microthread with platform margin model with 154 megapascal, while open microthread with platform switching had 101, closed microthread with platform switching had the lowest peak stress. The result of the study was that first generation scalloped implant design, which was no microthread with platform margin in this study, had the worst design for the bone stress. Open microthread with a platform switching had an intermediate stress design. closed microthread with a platform switching had a better design for reducing the bone stress upon loading. New generation of scalloped implant was produced with platform switching connection and microthread design for better stress distribution. Let me share a video how this new scalloped implant is used in clinical case. This is a case where traumatic tooth number 8 has to be extracted due to poor long-term prognosis. Korean FDA approved new generation scalloped implant was planned for the tooth replacement. After 4 months of healing, impression of the scallop implant was taken. Impression coping has a groove to give the orientation of the scallop implant. Implant abutment was fabricated on a model. A jig was used to orient the abutment in the patient's mouth. Implant provisional was delivered. Implant provisional was recontoured to match the facial gingival level of adjacent natural tooth. Then new impression for both implant and tooth was taken and provisionals were placed. This is the working model and the final restorations. Final restorations were delivered. This is another case that new scallop implant was used to provide the missing maxillary left canine replacement. Scallop implant was placed. Then healing abutment was placed. Soft tissue was sutured. 4 months of healing was allowed. Healing abutment was removed and impression was taken. Because the healing abutment was round and has no contouring, this was how the facial soft tissue looked at the time of implant provisional. Facial soft tissue contour is like a shirt hanging in the clothesline. Bone at the proximal side of the scallop implant is like clothespin that tightly holds the shirt. Let me explain the analogy. The proximal bone holds the soft tissue. The facial soft tissue travels in straight line from one end of proximal bone to the other side of proximal bone, because the shortest distance between 2 points is straight line. Since the healing abutment does not have any contour to alter the path, facial soft tissue profile is straight. Implant provisional contour needs to be modified and adjusted to change the facial soft tissue shape. This is a case that scallop implant was used to replace right first mandibular molar. This is the scallop implant used in the case. This is how the scallop implant was placed in the site. At that point, surgical instruments used for the scallop implant were the same ones that were used in round flat top implant. I need to make some modification of the surgical instruments to be suitable for the scallop implant, because scallop implant has 2 chances in every turn for proper orientation placement. Some iteration of surgical instrument and component modifications were made to be more user-friendly. Back to the case of replacing right first mandibular molar. Healing was allowed for 3 months. Provisional was provided for the implant. This is how the provisional restoration and soft tissue looked. Final restoration that has the same contour and the shape as provisional was delivered. In the same patient, scallop implant was used for right first mandibular molar replacement. Conventional implant with microthread and platform switching connection was used for left first mandibular molar replacement. These are the implants that were used and how the bone levels looked. This is case that healed the site where typical bone in buccolingual dimension is narrow at the crest top and gradually gets wider in apical direction. Because the facial height of the scallop implant is lower than proximal side, when the scallop implant is placed in this case, facial level is located in the area where thicker bone is present, thus avoiding bone grafting procedures. Provisional stage went through after the implant healing took place. This is a case that residual ridge was very thin. Guided bone regeneration graft procedure was performed first. 6 months after bone graft procedure, implant placement was attempted. The buccolingual dimension of the grafted site was very similar to previous case, that it was narrow at the crest top and got wider in apical direction. Scalloped implant was placed in the site. Because a scalloped implant has undulated platform shape, prepared osteotomy site matched the profile contour of the implant. Healing of the implant was allowed, then provisional restoration was provided. Implant provisional was tested. Then, final restoration was completed as the provisional. This is the X-ray of the implant at the time of final restoration delivery. The right photo is at the time of surgical implant placement. Let me share side-by-side cases where scalloped implants were placed just next to the conventional flat-top implant that have microthread and platform switching similar to the scalloped implant. I will share the cases when the flat-top implant were placed at the proximal level of scalloped implant, also when the flat-top implants were placed at the facial level of the scalloped implant. Let me start with the side-by-side case when flat-top implant was placed at the proximal level of scalloped implant. Two implants were planned and prepared in right maxillary posterior area. One scalloped implant and one flat-top implant were placed. 6 months of healing was allowed for both implants before starting restorations. Both implants, flat-top and scalloped implants that have microthreads and platform switching connection, show similar level of bone remodeling response. Let me share side-by-side case where flat-top implants were placed at the facial level of scalloped implant this time. 3 implants were planned for maxillary left posterior area. 2 scalloped implants and 1 flat-top implant were placed in this case. Bone grafts were placed at the defects after implant placement, and primary closure was achieved. 6 months of healing took place. Implant uncovery was performed. Healing abutments were placed. Flat-top implant was placed at the facial level of scalloped implant in this case. Let me share another side-by-side case where flat-top implant was placed at the facial level of adjacent scalloped implant. As previous case, 3 implants were planned for maxillary left posterior. 2 scalloped implants and 1 flat-top implant were placed. Bone grafts were placed at the bone defect. Then healing abutments were placed in this case for non-submerged approach. 6 months of healing took place. Implant restorations were carried out. This is X-ray of the case. Let's look at the bone level of scalloped implant and flat-top implant. Flat-top implant was placed at the facial level of scalloped implant. So, scalloped implant proximal level is much more coronally located than flat-top implant. This is the provisional restoration of the case. 2 scalloped implants and 1 flat-top implant. This generation of scalloped implant retains the similar level of bone as flat-top implant. Because the scalloped implant can provide scalloped shape of hard tissue underneath the soft tissue, greater facial gingival contour can be produced, thus creating scalloping soft tissue appearance. Let me share another case. This time, 3 scalloped implants were placed consecutively. Healing abutments were placed. After 3 months of healing, restorations were started. This is how things look at the time of provisional delivery. 2 months of provisional phase was evaluated. This is how things look after 2 months with the same provisional. Let's look at the papilla height when consecutive scalloped implants were placed next to natural tooth and next to flat-top implant. When the scalloped implant is next to natural tooth, papilla is the highest, meaning it is more coronally located. Papilla between 2 scalloped implants is slightly shorter than when it is next to natural tooth. Papilla between scalloped implant and flat-top implant is shorter than when it is between 2 scalloped implants. Observations thus far is that it is still the natural tooth that holds the papilla highest. then this version of scalloped implant holds the papilla higher than conventional flat-top implant. The take-home message that I would like to convey to the listener is that scalloped implant is not a substitute when soft and hard tissue are lacking. One must have enough hard and soft tissue for successful aesthetic outcome. This scalloped implant is a just adjunctive device that can help to achieve the clinical success when all other conditions are met. I must echo the advice that I received from USC endodontic faculty for this presentation conclusion. USC endodontic faculty once told me that there is no black magics in endodontics. I must say the same. This scalloped implant is not a black magic for aesthetic success. I don't know if you have watched this movie, Kung Fu Panda. In the movie, the main character, Po, asks his father for the secret sauce for his father's noodle. And his father tells Po that there's no secret sauce or secret ingredients for his noodle. The lesson that I have learned throughout my professional career in dental implant and endodontic is that there's no secret ingredients for success in dentistry. I hope that you enjoyed my voiceover presentation. Thank you for listening.